If you suffer from Parkinson's disease and you've been told that there's nothing you can do but take levodopa carbidopa for the rest of your life, I would bet money that that is inaccurate. There is always something you can do in anything, but specific to Parkinson's disease, Parkinson's by conventional medicine is considered to be a progressive neurodegenerative disease that you can't do anything about. You just take the medication until you succumb to the disease. But clinical experience in my office and basic science research reveal that there are causes and drivers to Parkinson's disease, and if you can find those causes and find those drivers and address them by optimizing them, you can slow the disease and maybe even reverse it in the sense that from a quality of life perspective, you don't even know you have the disease. And on a patient level, that's all you want, right? You want to return to what you were doing before. You want to return to moving at a normal pace. You want to return to being able to play with your grandkids and your children. You want to return to being able to sleep through the night without pacing the floor or having restless leg syndrome. This is all possible if you can find the causes in your unique and specific case and address those and optimize those. Levodopa carbidopa will never address many of the factors that can contribute to and exacerbate Parkinson's disease. All levodopa carbidopa is going to do is provide some dopamine hits for you every few hours as you take the medication. But if you're deficient in certain nutrients or have a blood sugar issue, it's doing nothing to address those things, and those things can be driving brain damage and exacerbating it and making your disease process go like this much faster than it needs to. So in today's video, I want to share a case with you that reveals that there are actionable targets. All you have to do is find them, and in order to find them, you have to work with a practitioner who is open-minded and has a detective mindset and realizes that there's more quality of life out there for you if we can just find and address the cause. I'm Dr. John Bartemus, and I'm putting the pieces together to help you live a life at optimal. Let's dive into the case. This is a 63-year-old male diagnosed with idiopathic Parkinsonian syndrome. What that means, idiopathic, what we're taught in medical school, regardless of what your license is, idiopathic means unknown cause. And so if conventional medicine is calling your diagnosis idiopathic, they're basically saying we don't know what the cause is, but here's a name for it. Okay, so he has idiopathic Parkinsonism is what they called it. And if they view it as idiopathic, then there's no hope for you to ever get better, right? Because if it's idiopathic, we say unknown cause, sorry, there's nothing we can do. Here's a medication to help manage your case and have a nice life. But is it idiopathic, or is that thinking idiotic? I think it's idiotic because at some point this man was healthy and over time developed symptoms that are now labeled Parkinsonianism. So that doesn't just happen overnight, and you don't go from being healthy to being diagnosed with a neurodegenerative disease overnight or for no reason. There's some dysfunction or some amount of dysfunction in his biology and physiology that allowed this disease process to be expressed. There's not an unknown cause. That doesn't happen with no known cause. That happens for known reasons or for real reasons that can be known if you search them out. And that's what we did. I didn't believe that it happened for no reason in him. He didn't believe it happened for no reason in him. His wife didn't believe it happened for no reason in him. Neither did his support group. We all wanted to find answers. They found me. We dove in and we found multiple biologic issues, physiologic issues, actionable clinical targets. So let's talk about those right now. The first one that they think is strongly related to the development of his Parkinsonian symptoms is his long-term use of the opioid agonist Suboxone. So Suboxone is an opioid agonist drug, meaning it promotes opioid receptor binding in the brain, and it's a painkiller, right? Or it helps reduce pain. And this person has a history of back injuries, back surgeries, and so the Suboxone was given to help with that. Well, in the research, it's been known since the 80s that opioid agonists can change dopamine production, dopamine reuptake, and dopamine metabolism, specifically in the substantia nigra and the striatum, so the part of the brain called the basal ganglia. Well, the basal ganglia is the part of the brain in Parkinson's disease that neurodegenerates, and it's highly dependent on dopamine to function. So potentially the Suboxone interfered with dopamine metabolism in the basal ganglia in this person and led to, or maybe contributed to, the neurodegenerative process that is resulting in Parkinsonian symptoms. Now, we can't do anything about that. He's off the medication now for those reasons, but we can't do anything to undo the potential damage caused by the medication. But does that mean there's nothing we can do and that he's hopeless? No. It means that matter has limitations, and after a certain amount of damage or a certain amount of time, there's no going back on that, but we can prevent further damage and we can optimize the tissue that's there and that's left. So that's our goal. And so the tissue that is still there, the brain, right? The brain tissue that's still there and functioning, we want to optimize that function. So one of the questions we need to ask is, what does the brain need to what does the brain need to function optimally? 3 things, okay? Stimulation, so movement, learning, etc. Oxygen, okay? And glucose. So the way that the brain receives energy and produces ATP so that it can function is through oxygen, glucose, and stimulation. And so those are 3 areas we want to evaluate through testing. And in this person, when we tested to look at oxygen levels, this person was iron deficient, okay? So if you're iron deficient, you are not carrying oxygen optimally and you're not delivering it to tissues. So if we're not delivering oxygen to brain isn't going to function well. And this person complained of brain fog and a lack of overall well-being and poor ambulation or walking, which is related to slowing down and Parkinsonism. But not just the brain suffers from iron deficiency, the whole body does. That's why the most well-known symptom is chronic fatigue or fatigue period, right? Well, iron deficiency also promotes inflammation. So increasing inflammation in the body promotes increased inflammation in the brain. Also, iron is a required nutrient for dopamine production and other neurotransmitters as well. So if you're iron deficient, you're not going to make dopamine well, and so dopamine production goes down. Dopamine reuptake is poor because there's no dopamine to reuptake, and so overall dopamine metabolism is poor without iron. Giving the levodopa carbidopa will provide some dopamine for him and help him move better and feel better transiently until the drug is metabolized out of the system, but we can't help his intrinsic dopamine production until we can give him the substrate needed to make it. Now, he also had lab high hemoglobin A1C. Okay, hemoglobin A1C is your average blood sugar over the last 90 days. Well, remember, the brain needs glucose, okay? But lab high glucose promotes insulin resistance. And if you're insulin resistant, you're not delivering the sugar to the cells that need it. Insulin resistance in the brain is called type 3 diabetes or Alzheimer's disease, another neurodegenerative disease, and the only one that's more common than Parkinson's. So this person automatically, when we say, what does the brain need to work? Oxygen, glucose, strike 1, strike 2, both are poor. The thyroid is key in brain function and function of every cell in your body because every cell has a metabolic rate. So this person walked into my office with a known diagnosis of hypothyroidism. And on the labs that we ran, this person had lab high T4s, lab high reverse T3. So this suggests that the person is over medicated with thyroid hormone and counterintuitively, so you might think, well, this person is probably expressing hyperthyroid symptoms. No, if you're so over-medicated, again, you can have that resistance, right? So thyroid resistance. If I poke you long enough, initially it's annoying, but eventually you just tune it out, right? Same idea. If we over-medicate you, eventually the receptors tune it out or down-regulate and resist. So he's feeling hypothyroid even though he's lab high in thyroid hormone. So therefore, his metabolic rate of his cells is less in the brain. If your metabolic rate is less, you may have brain fog, you may have anxiety, you may have depression, multiple potential symptoms. Okay. If we're talking about inflammation, inflammation decreases receptor sensitivity to hormones, to neurotransmitters, etc. Is this person inflamed? Absolutely. Our testing revealed lab high C-reactive protein, which is a systemic inflammatory marker. And if you're systemically inflamed, you're a short step from neuroinflamed or brain on fire. Okay? This person had lab high TGF-beta, which is another inflammatory and oxidative stress marker. And this person had lab high homocysteine. Now, homocysteine, if you check out previous videos that I've made, drives excitotoxicity in the brain. High CRP plus high homocysteine equals neuroexcitotoxicity. Cells blowing up, neurons dying, okay? And so if we have a neurodegenerative disease or process like Parkinsonianism, we don't want to be blowing up and losing extra neurons. So homocysteine, CRP, TGF-beta need to be brought down. Well, guess what? It is known in the literature that levodopa carbidopa increases homocysteine levels. So the same drug that he's taking to help improve his Parkinsonian symptoms is exacerbating his Parkinsonian symptoms potentially by driving up his homocysteine levels. So that's very important. We need to get these numbers down to decrease overall body inflammation and brain damage. One way to put fires out is with cortisol. We assessed his cortisol, and his cortisol awakening response, which is his 24-hour rhythm, is inverted. And at the same time, his melatonin was functionally low and not too far from lab low. So cortisol and melatonin oppose each other, right? When you wake up in the morning, you have a cortisol burst or a cortisol awakening response to wake you up and get you going in the day. Cortisol should be highest in the morning 30 minutes after you wake up, and then go down the rest of the day. Melatonin is lowest when you wake up, but ramps up in the evening when it's time to go to bed. He was flipped. So if you're flipped there, you're going to have trouble falling asleep, you're going to have unrestful sleep, you're going to wake feeling unrested, and you're going to likely have more pain because your cortisol rhythm is flipped and you're not putting out fires at the time and intensity that you need to. And also, if melatonin's low, melatonin is one of our best antioxidants, and so he's lacking the ability to help put out fires. Immune-wise, the immune system uses fire and rust to clear pathogens. Well, his immune system, his antibody levels were skewed. His IgA levels were lab high, his IgM levels were lab low. IgA levels function at the mucosal barriers, so those being lab high makes us wonder, is there increased attack at the gut, lungs, sinuses, bladder? IgM being lab low tells us, hey, his acute adaptive response to insult or infection is subpar. So that opens up potentially gut issues. And we know through research that the gut-brain axis is highly involved in Parkinson's disease, and oftentimes a decade before the first tremor, a gut infection occurred and traveled to the brain retroactively up the vagus nerve to cause inflammation and damage there. Well, this person had lab high levels of Proteus and Candida. Well, the Proteus bacteria is associated with Parkinson's disease in mouse models. So it's biologically plausible that the Proteus, if it's been there for a long time, had traveled retrograde up the vagus nerve and created a gut-brain axis exacerbation of the Parkinson's, if not cause. We can't say cause at this point because we don't know. It's been there for about 20 years, but right now we know that that can happen still, so we don't want to leave that bug there because it can exacerbate the process. All right, then lastly, B12 deficiency. B12 is the B vitamin that helps make, if my arm is a nerve, then we have what are called myelin sheaths on the nerves, okay? And between the sheaths are how the signals conduct down myelinated nerves. Well, B12 is needed to make the myelin. So if you're B12 deficient, you could have brain fog because of poor conduction of mental impulse, right? Or action potentials. If you are deficient in B12, you could be fatigued because B12 is key in the mitochondria in producing ATP and energy. Well, if we're already a poor energy producer because we're not delivering sugar and oxygen well, lacking B12 is just a third whammy for us. So I hope you can see from this constellation of findings in the same person that was labeled idiopathic, unknown cause of your Parkinsonianism. I hope you can see that you shouldn't hear idiopathic and give up, and you shouldn't even believe it, because there's always a cause. It just needs to be found. These things are all contributing to worsening of his case. The more that these things stay abnormal, the worse he will do. The more of these that we can optimize and create or return to normal, the better he will do, and the more his symptoms will be eliminated. So the goal is to focus on actionable items, focus on things that we can change to create hope for the person. And this provides a lot of hope because all of these things can be addressed, and all of them can be addressed without medication. All of them can be addressed using lifestyle like nutrition, physical activity, stress reduction, sleep hygiene, toxin avoidance, supplementation, etc., etc. You just need a clinician that knows how to use those things and how to combine them and phase them in a way specific to your case to be able to get you back to optimal. So if you're out there suffering from a chronic disease, chronic autoimmune disease, and you've been told there's no hope, it's idiopathic, we don't know the cause, don't believe it. Keep searching, seek out a detective clinician who looks for cause and looks for strong contributing factors, finds them, and then can partner with you to help eliminate those. And in that way, you will return to a life at optimal.